the ultrasound and echocardiogram part, we have already covered in another lecture earlier. So besides that, we'll cover the other aspects. It will include static as well as dynamic monitoring. We'll briefly touch upon the newer modalities as well. So before going into the details, let us start with the basics. For it is for everybody to remember that all pressures are measured in millimeter of mercury, ex CVP. So CVP is measured in centimeter of water, and it is for everybody to remember that 1 millimeter of mercury is equal to 1.36 centimeter of water, and odd cardiovascular pressures are reference to heart. That is called a phlebostatic axis, as you can see in the picture above. So this phlebostatic axis is actually uh, identified as it is located as an external landmark for the right atrium, and we go from a fourth intercostal space from approximately at the level of nipple, and we draw an imaginary line extending laterally, and then we draw a mid-axillary line, and where the two lines meet, it is called a phlebostatic point. So this is where we measure all the pressures, which is actually reference to right atrium. And the transducer is zeroed at this point. It is very important because if with every 1 centimeter change from this point, there is a 0.74 millimeter of mercury variation in the measured pressure. And every measured CVP, 1 centimeter change in the difference from this point actually changes the CVP by 1 centimeter. For arterial pressures like radial arterial or invasive arterial blood pressure monitoring, it may not make much of a difference. But for measurements like central venous pressure, intra abdominal pressure, and all those pressure, intra-abdominal pressure is actually not measured from this side, but just for the reference. But if you change the point by 1 centimeter or 2 centimeters, it increases the pressure by 2 centimeters. So the interpretation of the pressure may be false. So it is important to measure this point and keep a large scale in all the ICUs wherever you are working, so that we exactly zero the transducer at this point. Okay, and we level the transducer at this point, and in addition, we also do a zeroing. Zeroing, I think everybody knows how to do a zeroing. Zeroing basically tells us that the system which we use for measuring the pressures is actually counting the atmospheric pressure as zero. So whatever the difference of the pressure is from the atmospheric pressure, that is what we are measuring. Otherwise, we have to subtract the atmospheric pressure every time. So there are 2 points. One is leveling. The leveling is done at the phlebostatic axis, and zeroing is done at the atmospheric pressure. So this is where we level, and we also do zeroing. Zeroing means we open the system to air, and we reference that pressure to zero. So this is again the phlebostatic axis. This is where we measure the point. We take the point, fourth intercostal space, mid-axillary line, and from the phlebostatic point, we level the system. And this is how a simple pressure transducer and the measuring system looks like. There is a pressure bag, which is approximately inflated to 300 millimeter of mercury. And there is a transducer, which is leveled at the phlebostatic axis. This is connected to arterial line, and there is a saline filled non-compressible tubing. This tubing must not be very compliant. It must not be very long. We'll discuss in detail what happens if the tubing becomes compliant or if the tubing is very long. Okay, so how does it work? There is the pressure transducer. I think everybody has seen. That is what we use for arterial pressure measuring, invasive arterial pressure measuring, as well as invasive CVP measuring. So it is based on the Wheatstone bridge principle. So what happens is there is an interconnection of four resistances forming a bridge, as shown in the picture. There are four resistances which are forming a bridge. And what we are trying to do is we are trying to find out a value of an unknown resistance, which is connected to two known resistors and one variable resistor. So the transducer has four strain gauges, and it is fixed on the undersurface of the diaphragm. And the resistance of the two of them increases while the other two decrease. So this is a semiconductor type of technology, and the diaphragm is made of silicon, And as there is a change in wire's electrical resistance due to movement of diaphragm, it causes voltage change, which is proportional to pressure change. So this pressure change actually introduces a voltage change in the electrical, and with the change in voltage, there is a change in resistance. This change in resistance is actually measured, and it is converted, amplified, and displayed as a pressure waveform. So you have to mainly remember, this is a common exam question, that is the Wheatstone bridge principle, on which this pressure transducer is based. And there are two node resistances, one variable resistance, and with the pressure which is put on the diaphragm, this undersurface of the diaphragm has this Wheatstone bridge, which changes the resistance. With change in the resistance, there is a change in voltage, which so there is a change in resistance, which leads to change in voltage, and this voltage is sensed, amplified, and displayed as a pressure waveform. So coming to the components of arterial pressure waveform, I think most of you have seen this picture in your day-to-day practice. This is what a normal arterial pressure waveform looks like. There is a anacrotic limb, and then there is a systolic peak pressure. Then there is a diacrotic limb, and then there is a diacrotic notch, and then there is a diacrotic runoff. So this is simple. Besides looking at this waveform giving us a systolic pressure, the mean pressure, the diastolic pressure, it also gives us a lot of other information if you look at this waveform in detail, especially if this waveform is appropriate and there is no overdamping or underdamping in the system. That we will discuss what is overdamping and underdamping. So the anacrotic limb actually is systolic upstroke. So the systolic upstroke, you can see what is the rate of change of pressure with respect to time in this systolic upstroke. So steeper the stroke of this anacrotic limb, there is a faster rise of the systolic upstroke. This means that the LV contractility is very good. So if you see that this upstroke is quite delayed, and change in pressure with response to time is delayed, this means that the LV function may not be adequate. So you can also gauge, if you daily see the arterial waveforms, you can see whether the LV function is appropriate or not. This is not an absolute value that this is very specific to it, but you can get an idea what is your left ventricular function. And then there is a peak systolic pressure. So this indicates some maximum pressure in the vascular system. So in patients whose blood vessels are compliant, like patients with septic shock, or patients in anaphylactic shock. So what will happen is the peak systolic pressure will be low. Okay, so that is another thing which we can look at. Then there is a diacrotic limb, which indicates that there is the end of ventricular contraction, and there is a smooth downward slope for that diacrotic limb. It is interrupted by a sharp diacrotic notch. So everybody knows that this diacrotic notch corresponds to the closure of aortic valve. But this is not for so this is for the central aorta, or in the peripheral. As we move into the peripheral aorta, from central aorta, this diacrotic limb actually moves downwards and finally disappears. So you must have noticed that there is this diacrotic notch even in the radial artery waveform or in the femoral artery waveform. So what is that? That actually doesn't indicate that this is a closure of aorta. That indicates the reverberation or the reflective waveform phenomena. That will come in the next slide, what is reflective waveform phenomena. But you have to remember that in arterial pressure waveform, which is taken from the radial artery or from the femoral artery or any peripheral artery, this diacrotic notch is not actually corresponding to the closure of aortic valve. It actually represents a reflected waves which are coming from the periphery, which are and getting transmitted back to the central system. So this is about diacrotic notch. So how can we measure cardiac output from this waveform? So we can measure the area under the systolic portion of the waveform, and which indicates that this is the left ventricular ejection, and it can give us a approximate idea of systolic stroke volume and cardiac output. Then there is a diastolic runoff. So in vasodilatory state, what will happen is this diacrotic runoff will be very steep, while in vasoconstricted states, this diastolic runoff will be very narrow. So you can keep looking at this waveform and you can get a lot of information. about your patient. So coming into the details, as I was talking about, that there is a systolic peak pressure, systolic upstroke, there are diastolic runoff, and this is as we move from the root of aorta near the aortic valve to ascending aorta to the high descending aorta to mid thoracic aorta, aorta near the diaphragm. See, this diacrotic notch is disappearing, and the systolic pressure waveform is actually systolic peak pressure point is actually getting steeper. Okay, so why this happens? I'll tell you. This again is because of the reflected waveform phenomena. So what happens is as the pressure wave is transmitted from the central system, from the heart to the periphery. So there is a gradual. There are multiple waveforms which are getting transmitted, and there is a reflected wave which is coming from the peripheral system to the central system. So where those peripheral waveforms and the central waveforms meet, that actually forms a actual wave. So as the system, as in the radial artery or the femoral artery or other peripheral arteries, this is how the waveform, the arterial pressure waveform is created. So there is a forward flowing waveform. So at the end of the system, at the venous point, at where there is a venous point, what happens is there is a reflection of this waveform from the periphery. So these two waveforms actually combine and form a actual waveform. So this is what we see in a arterial distal or peripheral arterial pulses. So what are the, in nutshell, points to remember? So the points to remember is that as the blood pressure measurement is shifted from the center to the periphery, like from the central aorta to abdominal aorta to the radial artery or femoral artery, the systolic blood pressure increases because the component of reflected waveform is added into the main waveform, and the diastolic blood pressure decreases. So because the systolic blood pressure is increased and the diastolic blood pressure is decreased, the pulse pressure is increasing. The pulse pressure is high as we go from the center to the periphery, but the mean arterial pressure remains constant. So what is mean arterial pressure? So everybody has learned that formula that that is one third of the systolic blood pressure plus the diastolic blood pressure, all that. So but that formula is not valid for mean arterial pressure, which we get into in the invasive blood pressure monitoring system. So in invasive blood pressure monitoring system, in the arterial waveform, mean arterial blood pressure is calculated as an average arterial blood pressure throughout the cardiac cycle. So how it is measured? It is measured by area under pressure curve divided by time. So this is how the mean arterial blood pressure is measured. So this is the area under pressure curve divided by the time taken for that one pressure curve. So this is how the monitor calculates the mean arterial pressure, and it is determined by the, as we know, cardiac output as well as the total peripheral resistance, and most organs auto-regulate blood pressure as per mean arterial pressure. That is why we are measuring mean blood pressure and not we are looking at the mean blood pressure in our clinical practice, not systolic or the diastolic blood pressure. So this is how mean blood pressure is measured. So this, you have to remember that this is not calculated from the formula, because you must have observed, if you in your clinical practice, that if you calculate and add systolic and diastolic pressure and divide, and then calculate the mean arterial blood pressure from the formula, vis-a-vis if you look at the monitor and see the mean arterial blood pressure, that is different, because it calculates it from the area under pressure curve dividing that area by the time. Okay. So there are many interpretations. The systolic arterial pressure is a reflection of the LV afterload, and as we have discussed, the low blood pressures suggest that the stroke volume is low, maybe the cardiac function is not good. Then a diastolic pressure actually is a reflection of the vasomotor tone, as we said that if the vasomotor tone is less, like in septic shock, if there is a vasodilatory state, then the diastolic runoff is actually very fast, while in vasoconstricted states, this is a shallow diastolic runoff. So again, the pulse pressure is physiologically linked to stroke volume. The diastolic blood pressure is actually linked to arterial tone, as we have discussed repeatedly. You have to remember this, and you have to interpret your patients in hemodynamics as per this graph. Then in vasodilated states, you can see in a septic profile, if the diastolic blood pressure is less than 30, irrespective of the mean blood pressure, you should think of starting vasopressors. And in vasoconstricted state, there is a narrow pulse pressure, and then probably the stroke volume is also low. And this would also happen in a hypovolemic shock. Why the system is underdamped or overdamped, we'll see how we check the damping coefficient, how we'll check whether the system is working fine. But what is the overdamped or underdamped system? In an underdamped system, the systolic pressure will be high, the diastolic pressure will be low, the waveform will be narrow and peaked, while the mean arterial blood pressure remains unchanged. What are the reasons? As we discussed, the long tubing actually can cause underdamping, and increased vascular resistance can also cause underdamping. And for overdamped systems, basically it is opposite. It underestimates systolic blood pressure, overestimates diastolic blood pressure, but the mean arterial pressure remains unchanged. And what are the reasons? As most of us have seen, the air bubbles, or if the tubing is very compliant, or if there is a blood clot, fibrin clot, or no fluid in the flush bag, and if there are multiple connections, stopcocks, injection ports in the system, it all causes overdamping of the system. So it is recommended to keep the system free of air bubbles. The tubing should not be overly compliant. There should be no blood clots, catheter kinks, and there should be no stopcocks or minimum stopcocks as is necessary. So how do we check the damping of the system if it is an underdamped or overdamped system? So we do a dynamic response testing. I think everybody must have been doing this. This has to be ideally done once in every shift. So what we tell our nursing staff is to do it after taking over, every time you should check, or if you're taking a sample, or there is a change in the hemodynamics of the patient, or there is a change in vasopressors, you should also check your system before you directly move on to change it into increasing or decreasing the dose of vasopressors. You should check whether your system is working fine. So what we do is we do a square wave test that is called fast flush test also. So what we do is we open the valve of continuous flush device. I think there is a flush device. There's a flush device over here. There is a valve. We open the valve. It increases the flow to 30 ml of the normal saline to 30 ml per hour. These days, heparin is not recommended in the normal saline. The baseline flow is 1 to 3 ml per hour. This acute rise in pressure in the system causes a square wave on the bedside monitor. And once we close this valve, then there is a sinusoidal wave of decreasing amplitude. So for appropriate dynamic response, the sinusoidal waves should be 1 to 2 before it returns to the normal waveform pattern. But if there are more than two wavelets, it means this is an underdamped system. And if there are no wavelets, it indicates that the system is overdamped. And what about natural frequency? Natural frequency is the paper speed divided by time of oscillation. We'll see how we use it. And amplitude ratio is the amplitude in millimeter of two successive oscillations. That is D2 divided by D1. Okay, so that is amplitude of two successive oscillations that also we use to check the system. We will see how we use it. So you should remember what is the natural frequency, how we calculate. So paper speed generally is 25 millimeter per second, and amplitude ratio is amplitude in millimeter of two successive oscillations. We'll see. So this is how the fast flush test is done. This is a square waveform. Then there are two wavelets and sinusoidal wavelets, and then it returns to a normal system. This is the overdamped system where we don't see any of the wavelets. So this is fast flush test. Coming to the natural frequency, so the paper speed is taken into millimeter of mercury or millimeter per second. That we know what is the paper speed divided by the time which is taken for the one cycle. So this is the natural frequency of the system. So the natural frequency of the system should be above the frequency for which it should be, which is supposed to work. Otherwise, will not get appropriate blood pressures. Similarly, this is the amplitude ratio. This is how we measure it. D1, this is the first wavelet, sinusoidal wavelet, for which we calculate the amplitude. And then we calculate the amplitude for the second wavelet. And we divide it, and then we get the amplitude ratio. Then we can plot this amplitude ratio and natural frequency of the system in this graph, and then we can get we can see whether the system is working fine or not. But in simple day-to-day practice, this all is not done. We just do a fast flush test, and we can see how many wavelets are coming. So if there are no wavelets, the system is overdamped, and if there are more than two wavelets, the system is underdamped. Coming to the central venous pressure. So central venous pressure is actually a pressure in the thoracic veins near the right atrium. Everybody knows that it is a major determinant of preload of right ventricle or left ventricular and diastolic volume. It was supposed to be like that, But for that, there should be a linear relationship between ventricular volume and ventricular pressure in diastole, which most of the critically ill patients doesn't have. And this relation, we also assume that the relationship is constant in a given patient and between the patients, which is also not true. And we also assume that there are no AV valvular abnormalities, and the pressure in the left end ventricle at the end diastole correlates well with the CVP, assuming there is no increase in pulmonary vascular resistance, there is no increase in the change in pressures, which is in critically ill patients, everything is going haywire. So probably CVP is not a very good indicator of the preload, and what actually determines the venous return is the difference between mean systemic filling pressure and CVP. So we don't know mean systemic filling pressure from the CVP measurement alone. So we don't know what is actually how much is the venous return coming, and actually the CVP is not a very good marker for the preload. And so becoming, but still, it is of some academic importance. And sometimes we also do measure CVP when we see the change in CVP and we see the response to the volume. Still, it is being used in clinical practice, although we are not using it very frequently in our practice. So CVP has 3 positive and 2 negative deflections. I think everybody must have read this during their MBBS period. And A wave is indicative of atrial contraction. The C wave is indicative of closure and bowing of the tricuspid valve into the atrium after the atrial contraction is over. And X descent is actually for the atrial relaxation, which and change in the ventricular geometry. V wave indicates venous return and atrial filling when the tricuspid valve is closed. And Y descent actually indicates opening of the tricuspid valve when emptying of atria into passive emptying of atria into the ventricle. So Y descent, then A wave, then C wave, then X descent, so and V wave. So these waves everybody I think must be very familiar with. There are then some points to remember. So where the location of the catheter should be there when we measure the CVP. Actually, it should be at the junction of SVC with the right atrium. And in spontaneously breathing patients, during inspiration, intrathoracic pressure becomes negative. The CVP value will be lower. But in a patients on mechanical ventilation, the intrathoracic pressure increases during inspiration. So what happens is CVP is higher during inspiration compared to expiration. So when do we measure it? So CVP should be measured at the end of expiration, because at that point in time, pleural pressure is close to the atmospheric pressure. So that is the ideal point where even during spontaneous or positive pressure ventilation, we can measure a CVP. So where is that end of expiration? Where we measure the CVP? Because CVP has a wave, C wave, V wave, X descent, Y descent. So where do we measure? So it should be measured at the level of C wave. Why? Because it corresponds to right ventricular and diastolic pressure and aligns with R wave on ECG. But many times we will see that the C wave is not discernible. So if it is not visible, we have to measure at the A wave. So even if A and C wave both are not visible, what is the point? Then we have to measure it at Z point. Where is the Z point located? Actually, it is corresponding to the end of QRS complex and recorded as, so that is where we measure if A wave and C wave is not discernible. So ideal position is C wave. If not C wave, then A wave. And if not A wave, then Z point. So this was the earlier rule which many people used to follow, the 2-5 rule, that if we give fluids, measure CVP, then we give fluids. And if the CVP rise is less than or equal to 2 millimeter of mercury, then we give the fluids again. If CVP is more than 5 millimeter of mercury, we stop fluids, rise of CVP that is. And if the CVP is between 2 to 5 millimeter of mercury, then we should re-measure it after 10 minutes and then decide. Although Paul Merrick has actually challenged this theory also, because why? Because we don't know where our heart is working in our Frank-Starling curve. So the patient with CVP of 5 can be fluid responsive. A patient with CVP of 7 can be fluid responsive. A patient of the CVP of 4 may not be fluid responsive. So we don't know where are we in Frank-Starling curve, where we are based. A single value of CVP is actually not predictable of that the patient will respond to volume. So what is preload? I think everybody knows that it is the end diastolic volume in ventricle before contraction. And what is transmural pressure? It is a pressure that distends the ventricle. So it is the difference between the intraventricular and intrathoracic pressures. So intraventricular pressure we are measuring from the CVP. Intrathoracic pressure we are not able to measure, especially in critically ill patients, because patients with, on mechanical ventilation with PEEP, high intra-abdominal pressure, pericardial pleural effusion, which is very common in ICU patients, actually change the intrathoracic pressure. And so in the venous return is a difference of it depends on the difference of pressure between, as we discussed earlier, between mean systolic filling pressure and CVP. So we don't know what is our mean systemic filling pressure. So probably we are not able to get an idea of the patient, that how much patient is fluid responsive or how much preload the patient is, actually how much venous return the patient is getting, and whether this patient will be preload responsive, whether with giving the fluids, whether at particular value of CVP, will there be a hemodynamic response or improvement that we will see in for our patients. And mean systolic filling pressure is actually determined by stress volume. So what is stress volume? In the veins and the capillaries of our body, there is a lot of volume, which some of those that volume is not stress volume. Some of that volume is actually exerting a lateral pressure on the vessel walls, on the venous capillaries, on the venous capacitance vessels, that is small venules. So that amount of pressure that the volume is exerting, the same amount of volume, if the venous resistance is high, it can exert a higher stress pressure. And the stress volume, that is called the stress volume, the amount of volume which is exerting a pressure on the vessel wall can be higher for the same amount of volume. So we don't know where how much stress volume and how much unstressed volume that patient is having. So CVP doesn't give us any information about that. So this was a study, this is a paper by David Osman, and it actually told at the level of CVP, which is actually 2, some of the patients may be fluid responders and some of the patients may be feeling not responders. Similarly, with a CVP value of 16, some of the patients were fluid responders and most of the patients were fluid not responders. So if we take a mean value of 8, what they had shown that around 50% of patients were responding to fluids at the level of CVP of 8, and similarly around 50 to 60% of the patients were fluid not responders. So we don't know at what a particular value of CVP. We should take that value of CVP as a reference point to give fluids or not to give the fluids to a patient. And thus they concluded that cardiac filling pressures are poor predictors of fluid responsiveness in septic patients. Therefore, their use as targets for volume resuscitation must be discouraged, at least after early phase of sepsis that has concluded. And does central venous pressure predict fluid responsiveness? No. So that is clear. But does change in central venous pressure after fluid administration predict fluid responsiveness? No. So that is also, the answer to that is also no, because this is because of this paper which was published I think around 5-7 years back, and by Paula E. Murrick, and what they said was that in the systemic review they demonstrated that the relationship between CVP and blood volume, as well as the inability of CVP or change in CVP to predict the hemodynamic response to fluid challenges, very poor. So this change in CVP also doesn't predict whether the patient will respond to fluid or not. So we should not rely on CVP. We have better indicators, better dynamic indicators, echocardiogram, ultrasound, and all, to check if we can give fluids to the patient and if the patient has responded to the fluids or not. So this is another paper. You can go through this. This is a very beautiful paper by Daniela D. Becker. So what they gave us were around 7-8 points, which gave us that where we can use CVP in most of the cases when we cannot use the CVP. So what they told was that the predictive value of extreme CVP values like CVP of less than 6 or CVP of more than 15 is mostly satisfactory, but it is lower than the dynamic indicators. And similarly, there is no predefined safe upper level of CVP, and there is no target that we should achieve. CVP target is not well defined, and Most importantly, what they concluded was that CVP may fail to reflect intravascular pressure during mechanical ventilation. So that is a significant point, that most of the patients where we need these measurements are mechanically ventilated, and CVP cannot predict that. So CVP has become a very unreliable indicator. Coming to the second unreliable indicator, if you can say that, it is pulmonary artery effluent pressure, but still it is very important for us to know about it. So pulmonary artery pressure, I think everybody knows how to put in a pulmonary artery catheter. These days it is not very common, but the times when we were studying, actually, we used to put a lot of pulmonary artery catheters during our times, and it is a flow-directed balloon flotation technique with which we insert that catheter, and we continuously monitor the pressure during placement of the catheter. This is the waveform that we used to get. This is the waveform that we get when the catheter was in right atrium. This is identical to the CVP waveform. Then when the catheter went into the right ventricle, the systolic pressure of the right ventricle was higher, used to be higher, it is higher. So the waveform used to be like this. Then we actually when the catheter used to go into goes into the pulmonary artery, the pressure wave, the diastolic pressure actually goes above around 10 centimeter of 10 millimeter of mercury. And once we wedge that catheter, again the waveform is like a CVP waveform. Sorry for this. Yes, just a second. So waveform again used to be a CVP waveform. So that's it. That is how we used to identify where the catheter is at that point in time. And the pulmonary artery effluent pressure is a reasonable estimate of left atrial pressure if the mitral valve is normal, and left atrial pressure is also, then the left atrial pressure can also be corresponding to the left ventricular diastolic pressure. So this is how we used to directly measure the left atrial and left diastolic pressure by measuring the pulmonary artery effluent pressure. When we occlude the pulmonary artery, we inflate the balloon in the pulmonary artery. This is the pressure waveform. You can see this waveform and this waveform is almost similar. So you have to remember that once the catheter is, once the balloon is occluded, the catheter goes into the pulmonary artery, the balloon is occluded, it measures the capillary pressure, and then further it measures the pulmonary artery effluent pressure, which is equivalent to a left atrial pressure, which corresponds to the left ventricular pressure. So as I told, the waveform is similar to CVP with slight delay. C wave is usually absent. V wave actually surpasses A wave in PA, pulmonary artery effluent pressure tracing. And this you have to remember, the V wave is the largest wave here. And in mitral stenosis, mitral regurgitation, left atrial obstruction from myxoma, the left atrial pressure is more than left ventricular and diastolic pressure, and the PAOP, measured PAOP, is higher. And in pulmonary embolism, hypoxemia, there is an increase in pulmonary vascular resistance. Again, the pulmonary arterial pressure will be higher than the left ventricular and diastolic pressure. So there will be a falsely high measurement of left ventricular and diastolic pressure. Similarly, in myocardial infarction, diastolic dysfunction, AR, high PEEP, high intrathoracic pressure, the LVD EDP is actually higher than the measured pulmonary artery effluent pressure. So this fallacy you have to remember, and that is why it has also become out of common use, and because it was also a very invasive device, and there used to be a lot of complications, including pulmonary infarction, the artery rupture, and all that. And a lot of infections used to also happen. So there was a study which was published, which proved that the insertion of pulmonary artery, insertion of the pulmonary artery catheter and measurement of pulmonary artery pressures actually didn't change outcomes by much. So that's why it was taken out of the practice most of the times. And this is the index of transmission. This is also of academic interest. It actually measures the corrected pulmonary artery effluent pressure in patients who are on mechanical ventilation with PEEP. So what they do is they measure change in the airway pressure during ventilation and the fluctuation in the vascular pressure with each respiratory cycle. So the index of transmission was calculated as end inspiratory effluent pressure, pulmonary artery effluent pressure minus end expiratory pulmonary artery effluent pressure divided by the driving pressure. You can say the surrogate of driving pressure, that is a plateau pressure minus the PEEP. And finally, a corrected PAOP was calculated by subtracting the figure which came out of transmission index multiplied by P from the actual measured PAOP. And this is what the corrected PAOP was taken in a ventilated patient. Then there is a pulmonary capillary pressure. This is different from the pulmonary artery effluent pressure. This is pulmonary capillary. It is the pressure inside the capillaries of the pulmonary circulation. And capillary pressure was also estimated from the pulmonary artery catheter only. So, uh, uh, so what they do is that there is a straight line drawn tangent to the rapid component of the descent of pulmonary artery pressure to the pulmonary artery effluent pressure when the balloon was inflated. And two-thirds of the wave between pulmonary diastolic pressure and the pulmonary artery effluent pressure was taken as a pulmonary capillary pressure. Why pulmonary capillary pressure measurement is important? Because it tells us about the significant whether there is a lot of fluid which is moving out across capillaries, and there's a development of lung cardiogenic pulmonary edema. That was the main importance of pulmonary capillary pressure, but that has also come out of that test. Now coming to a very important point about the dynamic measurements of the heart lung of the measures of the pressure. So first we have to understand heart-lung interactions. So these are complex interactions between cardiovascular and respiratory physiology due to phasic changes in intrathoracic pressure during respiration. So we have to be very, so we'll go slow from here. So, so we have to understand these heart-lung interactions, because this is where we need to understand, we need to interpret our dynamic measurements of fluid responsiveness, all our pressures, and how we interpret that. And so we have to understand that what is heart-lung interaction? It is basically a complex interaction between a cardiovascular system and respiratory physiology. Why? During the phasic changes of intrathoracic pressure during inspiration. So during inspiration and during expiration, there is a phasic change in intrathoracic pressure, resulting in interaction between cardiovascular and respiratory physiology. So they are in connection, they are in a common mediastinum. So the pressure in one of the systems will affect the pressure in the other system. So what are the pressures involved? So first look at this diagram. There are two, for understanding purpose, there are the alveoli are these are the alveoli. In the capillaries near the alveoli are divided into intra-alveolar capillaries, which are very near to the alveoli, and extra-alveolar capillaries, which are relatively away from the alveoli. And so they are in a common system, they are in a common pleural space. And in addition, there is a heart. The heart has a right ventricle and the left ventricle, and these are commonly in a common thorax. So any pressure increase here will affect the pressure here, and any pressure increase or decrease here will affect the pressure here. So where the blood flows from the right ventricle to the pulmonary circulation, and from the pulmonary circulation to the left ventricle, and from the left ventricle to the systemic circulation. And how the blood goes into the right ventricle, as we discussed, it is the function of the mean systemic filling pressure and CVP. So the preload depends upon the mean systemic filling pressure and CVP, and the blood returns to the right ventricle. The right ventricle, it goes to the alveoli. So if there is a increased pressure inside the alveoli, it will compress the intra-alveolar capillaries, or the capillaries which are very near to the alveoli. So what will happen is the pulmonary vascular resistance will increase, but the pressures in the extra-alveolar capillaries will not increase, will actually decrease. So what is the net effect? Net effect is, again, during inspiration, during a positive pressure ventilation, there is a increase in effective PVR. So the peripheral vascular resistance, the pulmonary vascular resistance increases during inspiration. And what happens to the intrapleural pressure? It becomes positive. What happens to the intraalveolar pressure? It becomes positive during inspiration. And what happens to the preload? Because the intraventricular pressure has become positive, the CVP is increased, and the difference between the mean systemic filling pressure and CVP will decrease. It will lead to decrease in preload. So with inspiration in a positive pressure ventilation, the CVP will increase, the preload will decrease, and the venous return will decrease. What will happen during inspiration? The other thing which is happening is that the left ventricle the blood from the pulmonary vessels, that is intraalveolar vessels, or the vessels near the alveoli, gets squeezed from the pulmonary vessels to the left atrium, and it goes into the right atrium. So this is the second thing which is happening. One thing is the venous return has decreased, the preload has decreased during a inspiration. But other thing is happening, the pulmonary vessels are getting squeezed, and the blood from the pulmonary circulation is going into the left atrium. From the left atrium, it is going to left ventricle, and the cardiac output may increase initially. But ultimately, what happens is the effect of decreased venous return takes over, and the cardiac output, ultimately the left ventricle cardiac output, also decreases during positive pressure ventilation during inspiration at in a positive pressure in a patient with a positive pressure ventilation. What happens to the afterload? So what will happen to the afterload? So afterload also decreases. Okay, so we'll come next slides. We'll see how the afterload also decreases. So spontaneous respiration, there is a decrease in intrathoracic pressure during inspiration. There is increase in difference between mean systemic filling pressure and CVP. There is increased venous return. This is clear. During positive pressure ventilation, as I explained, there is a decreased venous return. But it is a transmural pressure. Transmural pressure is a pressure between is a difference between the intrapleural pressure and the intramural pressure. So during positive pressure ventilation, what will happen is the intrapleural pressure becomes positive. Okay, understood. Because this is a positive pressure ventilation. During inspiration, intrapleural pressure becomes positive, and the difference between intramural and intrapleural pressure actually decreases. And because this difference has decreased, it leads to decrease in afterload. So it leads to pumping out of the blood from the intrathoracic cavity to the other places. So the preload decreases, afterload also decreases in a positive pressure ventilation when the patient is inspiring. What happens in the spontaneous breath? It is opposite. The intrapleural pressure is negative. So during inspiration, it becomes negative, the transmural pressure increases, and afterload increases. And what happens in the positive pressure ventilation? So afterload decreases, and in negative pressure ventilation or spontaneous ventilation, afterload increases. And through spontaneous, the positive pressure ventilation decreases preload to the heart, decreases afterload to the heart, it augments the left ventricular outflow. So ultimately, the intrathoracic volume decreases. Now, when we initiate a positive pressure ventilation, what happens is the preload used to decrease because we are initiating a positive pressure ventilation. But what happens is the diaphragm moves down. The amount of stressed volume, blood volume, increases. So because the stressed blood volume has increased, it increases the mean systolic filling pressure, resulting in maintenance of preload. And so the preload has been maintained. Why? Because there is a activation of autonomic nervous system, there is tachycardia, vasoconstriction, there is increased intra-abdominal pressure, reduced unstressed volume. All these causes leads to maintenance of preload. That is why when we sedate and paralyze the patient while initiating a positive pressure ventilation, the stress volume remains the same, it doesn't increase, it leads to decrease in preload, and you must have been observing most of the patients become hypotensive at the time of initiation of positive pressure ventilation. So lungs expand, this I already explained. The second effect is that the lung volume decreases, and the pulmonary vasculature is compressed, the flow to the left ventricle increases, and initially it increases the left atrial preload and left ventricular preload, but ultimately, because of the decreased venous return, after 3 beats, the preload decreases. Okay, and what happens to the second phenomenon is ventricular interdependence. So what happens is the left ventricle and the right ventricular are generally connected. The left ventricular system is a high pressure system compared to the right ventricular system. So this is called ventricular interdependence in series. So what happens in the inspiration? There is reduced preload and stroke volume of the right ventricle. It reduces the preload of the left ventricle, but then there is a transient increase in preload due to squeezing of the pulmonary vessels, and it reduces the it increases the left ventricular preload. Then finally, what happens is that the left ventricular preload decreases because of the decreased venous return. Okay, and transient increase in preload due to squeezing of pulmonary vessels and reduced LV afterload actually signify that the left ventricle is at the steep portion of Frank Starling curve. So this is what is happening during inspiration. The impaired left RV function, augmented LV function increases the stroke volume. Okay, and after after 3 beats, what happens is the RV preload as well as the left ventricular preload increases. These changes in right ventricular preload, left ventricular preload is accentuated if the patient is volume deficient or if the LV is in the steep portion of Frank Starling curve. This is from where we measure stroke volume variation and its surrogates like systolic pressure variation and the pulse pressure variation. So understand, this is the most important point. So what we are trying to measure is the change which is happening because of the volume deficit. If the patient is hypovolemic, these changes will be accentuated. So the transient increase in preload due to squeezing of pulmonary vessels and reduced LV results in reduced LV afterload. And finally, after so what happens is there is a transient increase in preload due to squeezing of pulmonary vessels, and there is reduced LV afterload during inspiration, positive pressure ventilation. And when the patient finally, what happens is if the venous return is not appropriate, the LV preload and LV preload actually finally decreases. So initial there is increase, then there is decrease. You can see from here, initial there is increase, then there is decrease. So these changes in LV preload and LV afterload we measure and we correspond, and these measures actually correspond to the stroke volume variation and the systolic pressure variation and pulse pressure variation. So this is another thing. The LV and RV are also in parallel besides being in series. What happens is if there is a sudden increase in RV volume or if there is a sudden increase in pulmonary artery pressure, like in pulmonary embolism, the RV dilates. So what happens is the LV preload decreases. So otherwise, because LV is a higher pressure system, the interventricular septum is diverted towards the RV. But if the RV volume increases, it goes towards the LV. So this is how the ventricular interdependence works in parallel. So dilatation of the RV causes a shift of the septum to the left, reducing volume of the LV filling, results in reduced preload and stroke volume. So what is the diaphragmatic displacements? We already discussed. As we inspire, the abdominal pressure increases. There is a compression of splanchnic circulation. If the intravascular pressure in the system is more than intra-abdominal pressure, the venous return will increase. But if there is a patient having intra-abdominal hypertension or abdominal compartment syndrome, and if the intra-abdominal pressure is higher than the intravascular pressure, then the veins will collapse and it will reduce the venous return in a patient on a positive pressure ventilation during inspiration. So this also you have to remember. And dynamic measures, like coming to these dynamic measures, so they estimate fluid responsiveness from changes in preload produced by intrathoracic pressure changes during respiratory cycle. This we have discussed. And the magnitude of change in LV stroke volume or pulse pressure is magnified when the patient is preload dependent. The pulse pressure variation is the difference between maximum, minimum, and minimum pulse pressure value over one ventilatory cycle divided by average of two values. And stroke volume variation is derived from analysis of arterial pressure waveform. The cardiac output monitors use pulse contour analysis automatically calculate the stroke volume variation. And in mechanically ventilated patients with a tidal volume of 8 ml per kg predicted body weight, a pulse pressure variation of more than 12 to 13%, and the stroke volume variation of more than 10% is considered significant, and the patient may be considered as a fluid responsive. And in patients with arrhythmia, spontaneous breathing, and most of the patients as in ICU are low tidal volume, and the patients having low lung compliance, increased intra-abdominal pressure, as we had discussed, open thorax. And if the heart rate to respiratory rate ratio is less than 3.6, or the patient having bradycardia or increase, or patients with increased respiratory rate, which are commonly found in ICUs, these tests are not validated. So most of these tests actually are in post-operative stable conditions in patients in operation theaters where the tidal volume of 8 ml per kg can be given with the lung compliance is normal. Most of these patients doesn't have arrhythmia. in the intra-abdominal pressure is normal. In those patients, probably we can use these parameters, but in medical ICU patients, it becomes very difficult to use these parameters and interpret these parameters and manage hemodynamics of the patient based on these parameters. What are the newer tests to increase the sensitivity and specificity of these tests? These parameters. One is the tidal volume challenge. It increases the reliability of pulse pressure variation or systolic or stroke volume variation during low tidal volume ventilation. So what we do is we increase the tidal volume to 8 mils per kg predicted body weight for 1 minute in a paralyzed patient and observe change in pulse pressure variations and systolic pressure variation from baseline, and a change in pulse pressure variation of 3.5% and the systolic and the stroke volume variation of 2.5% after performing tidal volume challenge actually predicts that the patient may be responsive to fluids. And secondly, what we can do is we can do a lung recruitment maneuver, typically, which the books recommend as 30 centimeter for the 30 seconds, which we use. If we use, we increase the pressure from to 30 centimeter for 30 seconds, and if there is a decrease in stroke volume by 30%, so you can remember 30, 30, 30. And this also predicts fluid responsive. And most of the patients which you do recruitment maneuvers, you must be observing that there is a hypotension developing, but you also, in addition, can check if the stroke volume of the patient decreases by 30% if you have a continuous cardiac output monitor with you, and check if the patient can be fluid responsive. We can use fluids to obviate the hemodynamic compromise caused by the recruitment maneuver. The third thing is we also do a PEEP test. We decrease the PEEP to 5 centimeter of 5 centimeter of water, 5 centimeter of water for 1 minute, and in patients where the baseline PEEP is more than 10, and if it increases the cardiac index by 8.6%, it also predicts fluid responsiveness. It is a very good predictor with ROC curve of around 0.94. So this we have. What are the preload responsiveness methods to assess preload fluid responsiveness? Dynamic methods. We have conventional fluid challenge. The disadvantage is that once the fluid is inside the patient, we have to either remove it, and if the patient is having acute kidney injury, then the patient may get into volume overload. We can instead use a mini fluid challenge, but for that we also need to be very precise in our measurements of the cardiac output. And repeatedly doing mini fluid challenge can also cause volume overload. Pulse pressure variation and systolic pressure variation. We have discussed the pitfalls. And tidal volume challenge we have discussed. We'll discuss the end expiratory occlusion test. This is a very important test that people are using these days, but it cannot be used obviously in a patient who is not intubated, and it can also not be used in a patient who cannot hold his breath, who is not paralyzed, and who cannot hold his breath for 15 seconds. And IVC diameter variations in IVC diameter, variations in SVC diameter. This we have discussed in our earlier class, but we'll discuss passive blood training test in this test. So end expiratory occlusion test, it is reliable in patients with arrhythmias, moderate spontaneous breathing activity, low tidal volume, low compliance, independent PEEP levels, which most of the deficiencies of the test we have already discussed, that is stroke volume variation or the pulse pressure variations. And what we do is we do an end expiratory hold on a ventilator for 15 seconds, and we see if the change in cardiac output is more than equal to 5%. That is a positive test, or we can see the change in VTI by 5 to 9%. Different books mention different ranges, and can also be predicting a positive test. Similarly, we can combine end expiratory occlusion with end inspiratory occlusion, and this is more specific. And if the absolute added change in VTI is more than 13%, it actually predicts fluid responsiveness. This is what the graph look like. And coming to the PLR, it is one of the most important tests because it can be done in a patient who is not intubated, who is on spontaneous breath. It can also be done in patients who are having arrhythmias and who are being ventilated with a long tidal volume. But when we should not do this test, when the patient is of head injury and there is a increased ICP, and if the intra-abdominal pressure is high, it can lead to false negative test. And if we are using compression stockings, even then this test cannot be relied upon. It can also, in addition to predicting the fluid responsiveness, it can also be used to assess the possibility of vein-induced pulmonary edema. So basically, if the PLR is if the PLR is positive, the patient is responding to the fluid. It can predict that the patient may go into pulmonary edema when we try to change the mode of the patient from uh, positive pressure ventilation to the negative pressure ventilation. This is how it is done. Patient is placed to 45-degree head up, and then we measure the cardiac output, and it should be done with the cardiac output and not with the blood pressure. Then we make the patient supine, and from then we make the patient raise the legs to 45-degree. And then once the patient returns to baseline, and we measure the cardiac output again, and then we remeasure it once the patient is again put into the 45 normal recumbent normal position, that is 45-degree head up. So the most important thing is when to use this test. It is not that every patient in ICU who is coming to you should be assessed for fluid responsiveness. We should not be checking the IVC in all the patients. We should not be predicting, we're doing PLRs in all the patients. So if there is a sign of acute circulatory failure and there is a obvious hypovolemia, that initial phase of there is an initial patient who has come in septic shock, or if there is obvious hemorrhagic shock, you have to just go and do a volume expansion. But when you are confused that the patient may be in septic shock, maybe in a volume, or you have given initial boluses of the fluid, and after that you want to assess if the patient can be given more fluids or not. Then you have to see whether the patient is spontaneously breathing, having any arrhythmias, or if you are ventilating that patient with low tidal volume. If yes to any of these, you have to use either passive leg raising and a respiratory exclusion test or mini fluid challenge. But if it is none of these is there, then you can use pulse pressure variations or stroke volume variations or respiratory variations of IVC. And accordingly, you can see whether you need to give fluids to the patient or not. The second concept, which is very important, is the tolerance of the fluid. So every patient is fluid responsive. It's not necessarily the patient is also fluid tolerant. So every patient which responds by decreasing the heart rate, decreasing the blood pressure, increasing the urine output after giving fluids may not be able to tolerate those fluids. So what is tolerance? Tolerance is the ability of the body to receive infusions of fluids without progressing to organ dysfunction. So this is very important. So there is a concept of venous congestion. What happens is with the accumulation of the fluid with increased capillary permeability, there is a tissue damage in the microcirculation, which increases the diffusion distance, oxygen diffusion distance, and leads to hemodilution. It results in decrease in oxygenated RBCs. In addition, in patients with the increased vascular permeability in septic shock, there is a change in endothelial glycocalyx. And in the encapsulated organs, there is increased intraperitoneal pressures. So all this leads to increased venous congestion, and thus it leads to organ dysfunction. So besides the cardiac output, the organ perfusion is also dependent upon the venous pressure of that individual organ. So if the organs are congested and we are infusing more fluids, this infusion of more fluids may actually increase the organ dysfunction. So that is also a point which we need to look into, and because it increases the incidence of acute kidney injury, incidence of stay and mortality. So, so how do we check? So there are many methods. We check the right side of the heart, the left side of the heart. For the right side, we check the CVP, high Vexus score, venous reflex status, and IVC diameter. These are all the indices. I'll not go into the details of these indexes because of shortage of time. But these are the indices we check we measure to check if the patient is fluid tolerant on the right side of the heart. This is venous Vexus grading, in which we measure the hepatic artery, the portal vein, the renal vein, and the hepatic vein, portal vein, and the renal vein, and in addition to measuring the IVC. And on the left side of the heart, we check the pulmonary artery occlusion pressure, as we have discussed. We check if there are B lines on the ultrasound. We check E by E prime or E by A ratio. We also check the extravascular lung water or pulmonary vascular permeability index. And organ-specific measures, we check the respiratory system, the abdominal system, cardiac system, the renal system. So we can divide. If we need to check the respiratory system, we check the B lines, we check the extravascular lung water or pulmonary vascular permeability index, and so on. So these are the indices we measure to check whether the patient is fluid responsive. And thermodilution method, I think everybody knows. I'll not go into the details. So it is done with the PA catheter. It is these days this is very limited. We don't use it, and the thermistor detects the change in temperature near the near the pulmonary artery. And after infusing 5 to 10 ml of saline at 21 degrees Celsius into the CVP line, and this change in pressure is actually plotted. This change in temperature is actually plotted, and we get a cardiac output by event. And from that, we can derive the systemic resistance, PVR, cardiac index, stroke volume index, left ventricular stroke work index, right ventricular stroke work index. So this all values we get from our PA catheter measurements. These are rarely used because, as I discussed, there was a study which actually indicated that it doesn't make a difference in mortality or doesn't improve the outcomes, and actually increases the incidences of adverse effects. And so surrogate to this, there is a transpulmonary thermodilution, and there is an arterial catheter with a thermistor tip, which we insert in the femoral artery, and there is a central venous catheter. So in this method, actually, the thermistor senses the decrease in blood temperature after cold saline bolus, which is 15 to 20 mils, which is given through the venous catheter, and the cardiac output is calculated by Stewart-Hamilton algorithm. And the smallest change of cardiac output that can be measured is 12%, which is similar to the pulmonary artery catheter measurement. And it is a less invasive method where we are putting an arterial line and only a central venous catheter, which we generally put in a patient in ICU. And the temperature of the line is less than 8 degrees Celsius, and we have to ensure that there is no leak in the circuit. And the regularity of injection speed also defines about the accuracy of the measurement. And but the advantage is that it remains accurate during hemofiltration, valvular disease, atrial fibrillation, but in patients on ECMO, it cannot be relied upon. And a pulse contour PICO device and the volume view are the most commonly used devices which use this transpulmonary thermodilution method. From that, we get the cardiac output, cardiac index, and global end diastolic volume, pulse pressure, stroke volume variation, pulmonary vascular permeability index, extravascular lung water, global ejection fraction, and cardiac friction index. All these parameters we get from patient on patient with volume view or a patient with pulse contour analysis from the patient with the PICO device. And we also get intrathoracic thermal volume, total pulmonary volume, the global end diastolic volume, and all these can be used to manage hemodynamics of the patient. I'll not go into the detail, but the important point is the extravascular lung water and the pulmonary vascular permeability index. These two parameters actually give us how much of the fluid is there in the lung capillaries, and how much of the fluid is because of the hydrostatic edema and of the increase in hydrostatic pressure or the cardiogenic edema, and how much of that fluid is because of the non-cardiogenic pulmonary edema. So these measurements can be used, and this is a less invasive way. And the extravascular lung volume is lung water is calculated as intrathoracic thermal volume minus intrathoracic blood volume, which we get from the these monitors. And non-calibrated devices, these devices are calibrated. Non-calibrated devices can be connected to any arterial line. And FlowTrack and Vigilio is a prime example. These days, devices are not probably available. PRAM and Redco system are another devices which can be used. And the non-invasive, if you want to go completely non-invasive, you have a NICO device. This is based on the fixed principle and bioimpedance and bioreactance, which can be used. And most of these devices are actually validated for operation theater use. Most of them are not, as of now, validated for ICU or medical patients who are critically ill. And pulse wave transit time can also be used. That is the time taken from appearance of R wave on the ECG to rise point of pulse waveform in the pulse oximeter. Similarly, ultrasound dilution technique, this can also be used to measure central blood volume, total end diastolic volume, and active circulation volumes. These are developing techniques, and we need more time to go into the details of all these techniques. And we can also use electrical cardiometry and non-invasive cardiac monitoring from NextFin. So these are the values we get from them: the pre-ejection period, the left ventricular ejection time, non-invasive blood pressure, acceleration index, velocity index, intrathoracic fluid content. And from that, we calculate the stroke volume, cardiac output, SVR, left ventricular work index, and the systolic time ratio. these values are calculated and displayed in the system, and we can use them for monitoring the hemodynamics and managing the hemodynamics of our patient. So I think I should stop here because of the lack of time. And for any further questions, we are open. Yeah.
So we'll start the Q&A in a minute, sir.
Yeah. Hello.